Warm welcome. It's lovely to see you all with us. My name is Stephen Clift and I'm chair of today's webinar. This is the first of a series of 12 webinars on singing for health research and practice. The series has been planned by a team at the Centre for Community Music at York St John, the Singing for Health Network and the Royal College of Music. We're grateful to the Arts and Humanities Research Council for financial support that has made this series possible. And we're grateful too to the Singing for Health Network for hosting these webinars. Each event will be recorded, so you'll have the opportunity to view them again at your leisure. And we know there are people who've registered from around the world who won't be with us today because of time differences. I'm especially delighted that we're commencing the series today with a focus on singing and mental health and well-being. And we're all privileged to have 4 distinguished speakers presenting on a remarkable programme of work on the value of singing for new mothers experiencing postnatal depression. This programme started, I think, almost 10 years ago with the planning of a randomised control trial undertaken by Daisy Fancourt and Rosie Perkins, which was published in 2018. And I'm delighted that Rosie is with us today and she will act as a respondent when we've heard from our speakers. Subsequently, further research has been pursued on singing and postnatal depression within the ambitious SHAPER programme, SHAPER standing for Scaling Up Health Arts Programmes, Implementation and Effectiveness Research, with additional studies on dance interventions for people with Parkinson's and in recovery from stroke. In addition, work to explore the transferability of singing for postnatal depression to other countries in Europe has been supported by the World Health Organization, and we're going to hear about studies conducted in Denmark, Italy, and Romania. As we go on, please use the chat function to make comments and to ask questions, and we'll pick up on those later in the session. There'll be 2 further follow-up webinars on the theme of singing and mental health and well-being next week and the following week, and I do hope that you will register for those to continue on with these discussions. So without further ado, I'm pleased to introduce our first speakers. Becky Bind is postdoctoral research associate in the section of perinatal psychiatry in the Stress Psychiatry and Immunology Lab at the Institute of Psychiatry, Psychology and Neuroscience at King's College London. And Lorna Greenwood has worked in the arts for 15 years in various event production, project management and leadership roles, and she's experienced in scaling programs in a sustainable and strategic way for individuals and communities locally and internationally. So welcome, Becky and Lorna. We're really excited to hear what you have to say.
Oh, thank you so much for having us. We're going to be speaking to some slides today, so I'm just going to share those now. There we go. So we're going to be presenting together on this subject today. Myself and Becky have worked together for 5 years now, I think, on the SHAPER research study that Stephen mentioned, so we've got a lot of things to reflect and talk about. But just to introduce myself, my name's Lorna Greenwood. I'm head of scalability at Breathe Arts Health Research. And that also, my role includes the kind of management and oversight of our research partnerships. For those of you who don't know Breathe Arts Health Research, we're an award-winning not-for-profit social enterprise. We're based in London and we have over a decade's experience of co-designing and delivering evidence-based programmes across a range of art forms that are all designed to meet specific clinical health and wellbeing needs. Breathe Melodies for Mums is one of these programmes, and it's based on research by the Royal College of Music and Imperial College London that we've mentioned already, that showed weekly group singing could improve symptoms of postnatal depression faster than play or usual care alone. And Rebecca's going to talk in a bit more detail about the research behind this programme, Breathe Melodies for Mums, and also the evidence base we've built together through Shaper shortly. But just to bring Breathe Melodies to Mums to life a little bit, this programme is really designed with new mums at the heart, and its delivery continues to evolve in response to their feedback. The groups are led by specialist singing leads, and they use an international repertoire of songs in a range of languages, and they build confidence and connection through the teaching of those rounds and harmonies over a 10-week period. And they also weave in tools and kind of techniques for soothing and connecting with baby through song. And so they're very different to kind of your typical mum and baby groups. They're a completely nursery rhyme free zone. So to talk about where we deliver the programme, so since we translated the research into practice back in 2017, we've reached well over 1,000 new mothers and babies through delivery of the programme in various settings. And this slide just summarises the different settings we're working in. So in the community where most of our delivery takes place, we work in 5 different boroughs of London currently. And we've recently been commissioned by local authorities as part of their Start for Life provision in Southwark and in Croydon. And through that, they've also supported us to pilot a brand new programme based on the delivery model of Breathe Melodies for Mums, but working with and reaching new fathers. So I don't have time to go into that too much today, but I might reflect on it a bit later. We also have programs that are delivered online. We kind of pivoted to online delivery during the pandemic, and actually there is still very much a need for online delivery with this group of women and new parents that we're working with, because with symptoms that they might be experiencing due to postnatal depression, like feeling isolated or finding it difficult to leave the house, having a programme that you can access from your home is very, very valuable. So we tend to run those programmes still in the winter and in the spring when it's still quite cold and hard to get outside. We've also worked in hospitals, so in mother and baby units, 2 of them in London, so it's SLAM and Central North West London NHS Foundation Trust. And those programmes reach inpatients experiencing severe mental health issues, including postpartum psychosis. And we've worked with Kings, our colleagues, and Becky especially, and we've also worked together on that project, completed a service evaluation around the impact of that programme in that space. And then finally, we've worked in partnership with the WHO to on their Music of Motherhood project, which actually Calum and Katey will be presenting on later. We've delivered training to teams in Denmark, Italy and Romania on the delivery model we use to deliver Breathe Melodies for Mums in the UK, to give them the tools and skills and confidence to deliver that programme in the countries they know best. And an international community of practice is emerging around that work. So you can look forward to hearing a bit about that later. Pass over to Becky.
Hi everyone, I'm Becky, and I'm a postdoctoral clinical researcher, and currently I share my time between the Institute of Psychiatry, Psychology and Neuroscience at King's College London, and also at the Chani Kumar Mother and Baby Unit, which is part of the South London and Maudsley Trust. And as Lorna said, we've worked together for about 5 years now in 2 capacities, and one is on the Shaper trial, which we're going to talk about today, and the other capacity is on the Mother and Baby Unit, where Lorna came and helped to deliver some Melodies for Mum sessions. So my part of the talk today will more focus on the research side of Melodies for Mums. So just start off with a bit of background. So as of 2024, recent figures have estimated that postnatal depression can affect up to 24% of new mothers in the United Kingdom. And currently, while the gold standard for treatment still remains psychological therapy and psychopharmacology, many mothers with postnatal depression do experience challenges and stigma in accessing care, both at the individual and at the system level. And on top of that, many mothers have said that they don't want to take medication while they're breastfeeding. And so because of the lack of uptake and or the barriers that mothers are experiencing to accessing psychological and or pharmacological care, recent studies have highlighted the potential of community-based arts interventions for postnatal depression, and those include singing. However, the real-life effectiveness of such an approach in the community has not been fully tested in a large sample in comparison with other community interventions. And so Melodies for Mums is an intervention that was developed and tested as part of a collaboration between the Royal College of Music, Imperial College London, and University College London by Daisy Fancourt and Rosie Perkins, who of course is part of this call today. And in 2018, Melodies for Mums was tested in a 3-arm randomized control trial involving 134 mothers who were experiencing symptoms of postnatal depression. And in order to be eligible for the study, they had to have scored at least a 10 on the Edinburgh Postnatal Depression Scale at baseline. And the study compared the efficacy of community singing with a comparison group, which was 10 weeks of creative play classes for mothers to attend with their babies, and also compared that to a waitlist control group. So the mothers just received 10 weeks of their care as usual. And this pilot study found that mothers who were experiencing moderate to severe symptoms of postnatal depression, so defined as an EPDS score of greater than 13, who participated in the singing program with their baby, showed a significantly faster improvement in symptoms than the mothers who were in usual care. And so following this pilot study, Melodies for Mums was taken on as a service by Breathe Arts Health Research across the boroughs of Lambeth and Southwark in South London. However, since then, there had been no further research on the program, and so thus its effectiveness on a larger scale remained to be evaluated, as did the acceptability, the appropriateness, and the feasibility of its delivery on a larger scale, as well as the potential to be adopted and sustained as a cost-effective, beneficial service for mothers within the NHS. And in addition, there was no evidence on the effect of Melodies for Mums on the mother-infant interaction, nor was there detailed mechanistic investigation of the biological underpinnings of any therapeutic effects of the intervention. And so in order to address those questions, we evaluated Melodies for Mums on a larger scale. And so in order to understand its clinical effectiveness, its implementation effectiveness, and the cost effectiveness, we launched the SHAPER program, which is a randomized control trial funded by the Wellcome Trust. So on the left, you'll see a photo from our SHAPER PNDO trial, which I'll discuss in a moment, which took place during the COVID lockdowns. And so the singing groups had to take place on Zoom. And then on the right, you'll see a photo from our in-person SHAPER PND trial when the singing groups were able to take place in children's centres again. So first, I'll just talk about the SHAPER PNDO trial. And so essentially, our in-person trial was set to begin right as we went into the COVID lockdowns. So as a result, we quickly pivoted and we created an online adaptation of the Melodies for Mums program. And so the PNDO study was essentially a single-arm 6-week trial, meaning that all mothers and babies who enrolled in the trial were allocated directly to the singing, and there was no comparison group. And they took part in the singing sessions for 6 weeks with their babies on Zoom. And we ran this study throughout 2021, and we recruited 37 mothers and their babies into the trial, and they didn't have to be just in London. They were coming from all over the UK onto the Zoom sessions. And our main outcomes that we were looking at were firstly to assess the feasibility of delivering the Melodies for Mums program in an online format, and also to assess the clinical effectiveness of the online sessions on mothers' mental health and well-being. And so we assessed mothers at baseline before they began the singing sessions, mid-intervention, so around week 3, at the end of the intervention at week 6, and then at 2 follow-up points a few months later to see how they were doing beyond the singing sessions. And so if anyone's interested in looking more at the results, I've included a screenshot here of the paper that we published. So in terms of our primary feasibility finding from this trial, we found that while recruitment was lower than we'd anticipated, our study retention was very high, and 87% of mothers who enrolled in the study completed each follow-up point through to the end of the study at week 32. And we also found that mothers attended on average 5 of the 6 singing sessions, which was quite a high attendance rate. And in terms of the clinical effectiveness, on the right, you'll see a figure that shows mothers' trajectory on the EPDS, which is the depression scale, across time. So they filled it in baseline, week 3, week 6, week 16, and week 32. And what we saw was that mothers experienced a significant reduction in symptoms of depression as early as week 3 of the trial, and they continued to improve between week 3 and week 6. And importantly, what we also saw was that the antidepressant effect of the singing sessions was still present at the 32-week follow-up time point, suggesting a long-lasting effect of the online singing groups. Interestingly, something else that we found was that mothers who had experienced childhood maltreatment tended to respond less to the treatment, but this was pretty consistent with literature that childhood maltreatment might be associated with a treatment-refractory depression. So the trial also had secondary outcomes, which were looking at other aspects of maternal mental health and well-being. So what we found was that mothers also experienced significant reductions in the severity of their depressive symptoms and different types of symptoms of depression by week 6, and also as early as week 3. And that was seen on both the Hamilton Depression Rating Scale and the Beck Depression Inventory. And so consistent with the EPDS, this effect was sustained through to week 2 with the BBI. Through to week 32. And in terms of other domains of mental health, mothers also reported a significant decrease in their symptoms of anxiety, which was seen through the State Trait Anxiety Inventory, and their symptoms of stress, which was seen through the Perceived Stress Scale. And again, both of these effects were seen by week 3 of the intervention and sustained through to week 32. And finally, we looked at mothers' overall well-being with the ONS scale, which rates a person's perceived satisfaction, worthwhile, happiness, and levels of anxiety. And what we found on this was that mothers reported a significant increase in their life satisfaction and their sense of worthwhile between baseline and week 6. So our overall takeaway from the online trial was that online Melodies for Mums was both feasible and clinically effective as an intervention, especially in times where barriers are preventing access to in-person care. And moreover, that the antidepressant and anxiolytic effects of the intervention were meaningfully long-lasting. So when lockdown restrictions eased in September of 2021, we were able to start our in-person trial, Shaper PND, which was a 2-to-1 hybrid implementation clinical effectiveness trial. And on the right, I've put a photo of our protocol paper in case anyone is interested in reading that. And so essentially for this trial, we recruited mothers with postnatal depression. So they had to score again at least a 10 on the EPDS with babies aged 0 to 9 months. And mothers were randomly allocated to either 10 weeks of the Melodies for Mums intervention or to an active waitlist control group, meaning mothers were allocated to another mother-baby activity within the community while they waited to be offered the singing sessions after the intervention period. And so just to note, mothers in both of the groups were kept in touch with by the research team and by Breathe throughout the 10 weeks, and they were monitored for safeguarding as well. And so over the course of the...
there's 10 minutes, further 10 minutes if you can manage that.
Maybe we can skip ahead. Maybe one more. Yeah, okay. So in terms of the clinical effectiveness objectives for the Shaper trial, our primary objective was that the intervention would reduce symptoms of postnatal depression. And our secondary objectives were that it would also improve other aspects of mental health and well-being, like anxiety, stress, and loneliness. And furthermore, that it would improve the mother-infant bond. And finally, one objective was to understand whether certain biological mechanisms underpin the psychological outcomes observed. So for example, whether mothers experience changes in their cortisol output and their oxytocin. And then in terms of the implementation and cost effectiveness objectives, we were looking to assess the acceptability, appropriateness, and feasibility of the intervention compared with the control group activities. And then finally, to understand the cost effectiveness and the sustainability and scalability of the program. This might be a bit hard to see, but this is essentially a flow chart from the trial. And as you can see, we assessed 255 mothers and babies for eligibility, of which we enrolled 199 into the trial. So 133 of the mothers and babies were randomized to receive singing, and 66 were randomized to the control group, since it was a 2-to-1 trial. Unfortunately, we had 6 mothers who immediately withdrew after being randomized to the control activity. And then we looked at participant retention for our main outcome, the EPDS, and we saw that 148 mothers filled in the EPDS at week 6, 130 at week 10, 117 at week 20, and 108 at week 36. So of note, one of our primary findings so far has been that the singing group had a significantly better retention at each study time point and throughout the course of the trial, which already tells us something about the quality of the activity that they were assigned to, and that mothers were much more likely to remain engaged with the singing than they were with the control activities, possibly because they were finding greater benefit in it. So many of our findings are actually still in process of being analyzed since we just wrapped up the trial a few months ago. So we've put a list here of what we're currently working on and what's to come soon. And so firstly, we're examining whether the mothers in the singing group had a greater and or longer lasting decrease in their EPDS scores over the course of the intervention and through the follow-up periods. We're also examining whether Melodies for Mums impacted other aspects of mental health. So we're looking at the mother's levels of anxiety, stress, well-being, and whether there are any maternal factors that may influence their treatment response. So for example, in the online study, we saw that maternal childhood maltreatment impacted their treatment response. And we're also exploring potential mechanisms involved in the clinical efficacy. So like I said, the biological changes that mothers and babies may be experiencing, or perhaps changes in their relationship. And we'll be examining focus group interviews conducted with the singing participants to understand the active ingredients that may drive the implementation effectiveness of the program. And we're in the process of analyzing the cost effectiveness of the Breathe Melodies for Mums program. And so as well as its cost compared with other community mother-baby activities and its scalability and sustainability to be a wider reaching program. So some results that we do have ready to share today are from the implementation effectiveness side of the trial. So what I'm showing here is some quantitative data. And so at week 6, so mid-intervention period, mothers in both of the groups were asked to fill in questionnaires about the feasibility, acceptability, and appropriateness of the activity that they had been assigned to do with their baby. And questions were rated on a scale of 1 to 5, where 5 is the highest. And as you can see, mothers in the singing group found their activity to be significantly more feasible, acceptable, and appropriate for postnatal depression than mothers in the control group. And I've just included the questionnaires on this slide in case anyone wanted to have a look at what exactly the questions were that the mothers were filling in. Lorna, you're muted.
Thank you. I'm going to talk about some of the other implementation findings. And I just wanted to say thanks to Dr. Emmeline Han, who led the write-up of these, and Dr. Alexandra Burton at UCL for their input on this presentation. So this research looked at the implementation of singing groups through the experiences of participants and professional stakeholders, and it aimed to evaluate the perceived acceptability, appropriateness, and feasibility. So obviously Becky's talked about the quantitative data relating to that, which showed high levels of acceptability, appropriateness, and feasibility. And the qualitative data we collected was from 22 participants and 15 professional stakeholders. And we analysed this using the INNATE framework. You'll notice that Katey's name is leads this framework. We identified through using this framework 16 core ingredients of Breathe Melodies for Mums for implementation across 3 categories. So that was context, people, and project. So I'll just share, because I think it's really important to hear the voices of the people that participated in this programme and participate in this programme. So giving you an example of each of those ingredients. And the first is a project ingredient, where there were 6 identified, and interviewees affirmed that communal singing was appropriate for postnatal depression. And they said singing in rounds helped one woman to make eye contact with other people instead of socially withdrawing on a bad day, and helped another to focus on something other than her anxiety. And this quote supports that. So I think the communal singing aspect made me feel relaxed. It made me feel calm. There's something about singing, especially when you're doing it as a group in a round, you really have to focus on what you're doing. So it put my head in a different space and helped me switch off from other negative thoughts or anxieties. The second example is a context ingredient, and there were 3 of these identified. And interviewees felt Melodies for Mums was advertised in an acceptable way, and to strengthen partnerships with healthcare professionals, stakeholders, recommended doing taster sessions to really get the buy-in of stakeholders, and sharing research evidence and communicating feedback on the progress of participants back to the people that were referring them. So there's a quote here from a referrer that's quite useful. As a perinatal service, you get a lot of emails about different groups and things they're running. And as a busy clinician, you don't always have it in mind. Having had a positive experience of referring someone, it's a bit more at the front of my mind to offer to other people. And then the final example I'm going to share is a people ingredient, of which there were 7 identified. And Breathe Melodies for Mums as a shared activity was also found to be appropriate to participants. So babies would recognise songs and respond positively when their mothers sang them to them at home. We actually give participants access to an online hub with recordings of the songs, so they can go away and listen to them at home with their baby between the sessions, but also share them with the wider family unit. As a result of this, mothers felt better able to engage with their babies. And this is a lovely quote to finish this section on. When I talked to my daughter back in the day, sometimes she wouldn't look at me or make eye contact, which made me nervous. And as soon as I went to Breathe Melodies for Mums and then I sang at home with her, she could make eye contact, and that was amazing. I do have a video to show which really brings the programme to life. It's just a few minutes long, and you'll also hear some of the voices of the participants we've worked with over the years within it. So
I think we should move on. I'm so sorry.
Yeah, no, that's fine. I thought that might be the case. So what I'll do is we can always watch it at the end if there's time.
Exactly.
So,
well, it will be available for people to view, and this is on your website, isn't it? This particular video.
Yes, so, it is. And I can put a link in the chat to it as well. But
thank you very much.
Just to finish, this is the social media links to both Breathe Arts Health Research and Rebecca's lab, the SPY lab at King's College London. And you can find out more about our research through this QR code here. But just to say, I think all of us involved in this Shaper project really hope this research will really strengthen the compelling evidence base behind arts and health interventions. We know there's a huge amount of evidence there, and we'd really love to see, impactful evidence-based interventions like Breathe Melodies for Mums being commissioned at scale to reach more people. But we recognise that partnership is key. And I just wanted to mention that actually earlier in the year, we had a collaborative event with the National Centre for Creative Health, where we focused on collaboration to scale and implement arts and health interventions. So I think that's our hope for Shaper. We'll leave it there. Thank you very much.
Thank you, Becky. Thank you, Lorna. I'm just going to click on that. Oh, I've not seen that before. Thank you so much. Let's move on then. I'd like to introduce Katey and I'd like to introduce Katey and Calum. I won't read what I've got here just for the sake of saving some time. You probably will want to just introduce yourselves. So if we could turn to you now, Katey and Calum.
Absolutely. Thank you very much. And thank you for having us here today. And that was a wonderful presentation there about the Shaper project. And I think what we're going to say is really going to complement what we've already heard, which is wonderful. So just to briefly introduce myself, my name is Katey Warran. I'm a researcher based at the University of Edinburgh, where I'm currently doing a Lieberhume Fellowship, but I was previously based at University College London in the Social Biobehavioural Research Group, which is a WHO collaborating centre for arts and health. And I still work there as an honorary fellow and work on various projects. So what we'll be talking about today is a project that was conducted with UCL that I was involved in leading with Calum on the research element side of things. And it was a partnership between WHO Europe and UCL. And I'll hand over to Calum to just briefly introduce himself as well before we get started.
Thanks so much, Katey. Everyone, lovely to see you. Thanks so much to the webinar organisers. My name's Calum Smith. I'm a doctoral candidate in population health at Oxford University, but my role in this project was as a consultant for the WHO Regional Office for Europe, where my role was to help with the project management of this intervention. Katey, back to you.
Thanks so much, Calum. So in this presentation, we're going to start by giving you some background to the project. And actually what you've heard already today is quite a lot of background to what we did as well. So please bear in mind your previous presentation as you hear what we're going to say as well. And following this bit of rationale and study design, we'll share a short video. It is 3 minutes long, but we think it is quite essential to get a sense of what it was really like when we delivered these sessions in different countries, particularly with a focus on Romania. And then we'll talk you through some of the findings of our project, before exploring some of the publications and resources from the project that are currently available. And we'll discuss some next steps as well, which we hope will open out to the discussion that we'll have. So as a bit of background, arts interventions are known as complex interventions in the context of medical research because they combine a whole range of different components, also known as active ingredients, which you've just heard all about within the innate framework from the previous presentation. And the idea is that these active ingredients may prompt multiple causal mechanisms, also known as responses, that lead to health effects. So based on a wide range of literature, we put forward this logic model that shows how singing is one such highly complex social activity. So if we start by looking at the outcomes part of the model on the right-hand side, we have mental and physical health, and we know that these may be bidirectionally interrelated. Now, thinking back from this to the responses or the mechanisms part of this model, these can be understood within 4 broad categories of psychological, physiological, social, and behavioral responses. And these responses are known to affect the onset and the progression of mental and physical health conditions. Now coming to those ingredients or those components of the singing intervention, singing involves a whole range of different components that we know to be beneficial for our health, such as cognitive stimulation and social experiences and some of the other ingredients that we've just heard about. Essentially, it's more than just the act of singing. So reflecting on this model, we can see that there's a really strong rationale for implementing singing interventions to combat complex health challenges. Again, we've already heard a little bit about this, but one example of how singing has supported mental health is in the case of postpartum depression, building on some research that was conducted by the Royal College of Music and Imperial College London. This was a randomized controlled trial, as you've already heard, that was looking at singing versus play. And it's really wonderful to have Rosie here today as well, who's led on this research. So I'm sure we will have a really interesting discussion about this later. I'm not going to go into too much about this because I think we've already heard it, but I think the important thing to note here is that what it found was that mums with moderate to severe symptoms of postpartum depression reduced symptoms by up to 38% and led to a faster recovery when compared to usual care. So what this study shows is that it builds on long-standing and new research showing that music can be beneficial for expectant and new mothers, supporting both maternal mental health and bonding between mother and baby. So this was essentially our foundation, and as a well-evidenced intervention, we chose to implement music and motherhood as a case study to explore the adaptation of this arts intervention for new cultural contexts. With this in mind, these were our 2 primary aims. So firstly, we wanted to evaluate the feasibility of implementing the music and motherhood intervention in the new cultural context of Denmark, Romania, and Italy. So is it even possible? What do we need to do? We wanted to work in partnership with in-country partners and to collaborate on exploring how this may happen, how we might be able to do this. And secondly, we wanted to evaluate the perceived impact of the intervention on mental health and well-being for intervention participants. Now, although our primary aim was to explore implementation and adaptation, this secondary aim was also important to understand if the intervention would support the mothers in a similar way to what had been seen in the UK study. So we weren't looking at clinical effectiveness here. We didn't have a control group. It was very much an evaluation of did the mothers feel that this had a positive effect on them, which we could then frame within our implementation findings to explore if this was a successful thing to implement. I'm now going to hand over to Calum, who's going to say a little bit about the structure of the project.
Perfect. Thanks so much, Katey. So as Katey said, we'll talk about results, findings, outcomes and stuff shortly, but it's worth stating because this was an implementation and adaptation study, the way that in order to explore these aims, we had this huge network of partners and contacts that helped work together to implement in these different spaces. So some of the key groups involved that are worth mentioning are Den Creative School, our partners in Silkeborg in Denmark, Cluj Cultural Centre, our partners in Romania, and Instituto Superior di Sanità, our partners in Italy, as well as Breathe. And I think partly why we have this image here is to show the interconnectivity, the learning, and the sharing of experience between the groups. And as we're looking at adapting to different cultural contexts, this visualization of partner institution helps to show how, for example, PPI and research were mutually informative as we developed this process, how recruitment happened differently in different locations. If you want to learn more about this, you can read one of the papers that I'll be talking about shortly. But yeah, in adapting to different cultural contexts, we felt it was essential to document the knowledge sharing and learning that passed between individuals, groups and organizations, both within and between countries. And before moving on to the processes of data collection, we thought we could now share and pause and focus on some of the participating mothers. And for this, we've got a video made by some of our colleagues in Romania, which hopefully should play now.
Prima dată este o etapă de încălzire fizică și vocală și apoi sunt niște exerciții jucăușe, tot muzicale. Și, de exemplu, la prima oră am învățat un cântec, data viitoare deja am încercat să adăugăm o mică coreografie, data următoare deja am reușit să cântăm pe voci.
Ora de cântece pentru mame și bebeluși a devenit pentru mine în scurt timp unul dintre cele mai așteptate momente ale săptămânii. Pot să spun că a fost o experiență foarte binevenită în perioada asta a vieții și cred că a fost și o experiență terapeutică. Eu personal m-am simțit cu adevărat mai bine de-a lungul celor 10 săptămâni și cred că asta se datorează într-o bună măsură și orelor de cântece.
Semmilyen elvárásunk igazából nem volt. Örültem, hogy jöhetünk egy olyan helyre, ahol még beszélgethetünk így az anyukák között, mert hogy előtte és utána is van erre lehetőség. Nagyon érdekesnek találtam, hogy ez az egyetlen klub, vagy esemény, ahol az anyukákra terelődik a fókusz. Amit mindenképp megemlítenék az, hogy mi egy alkalmat hagytunk ki eddig, és azon a héten úgy éreztem, hogy visszatért a menstruációm, vagy legalábbis ez a premenstruációs szindróma. Tehát válni akartam, ingerlékeny voltam, minden, ami e körül lehet. És nagyon-nagyon fogtok hiányozni.
Când ești și faci parte dintr-un grup de oameni care cântă nu profesional și nu pentru un public, ci pentru ele în sine, atunci simți că muzica chiar are o putere fascinantă și că este chiar un limbaj fără judecată. Deci în momentul în care tu depășești acea limită și nu te mai judeci și ai curajul și încrederea să-ți dai drumul la voce, atunci se schimbă ceva în tine și când faci chestia asta, deci când împreună cu alți oameni și depășești bariera asta împreună, este minunat. Deci eu cred că asta este valoarea proiectului.
Okay, so hopefully that's given you some insights into the structure of the project and the project partners and how important those project partners were and what was actually happening on the ground. So we'll now say a little bit about what we actually did from a research perspective. So the full protocol for the study is available online. I've created a shortened link on the screen for you if you'd like to take a look as well, and I'll give an overview of the study design now. So we included 4 participant groups, so singing leads delivering the intervention. These were professional singing leads. The mothers participating in the groups, referrers who referred the mothers into the intervention, and managers and partners involved in managing in the project. So importantly, we were trying to involve absolutely every person who was involved at every level of the infrastructure from that model that Calum's just shown. And for the mothers, we collected data on both implementation and impacts. That's our first and our second aim. We collected quantitative surveys on postpartum depression, social support and wellbeing at baseline, and then week 6 and week 10 alongside a focus group to explore impact. And then we additionally conducted one-on-one interviews with a selection of mothers to ask questions about feasibility of implementation. So we wanted to know, is it feasible for them? For singing leads, we conducted one-on-one interviews, and for referrers and managers, we conducted a focus survey, which actually built on the King's College design that you've just heard about. The study design was also informed by implementation science frameworks, for example, the RE-AIM framework, which stands for Reach Effectiveness, Adoption, Implementation, and Maintenance, and Medical Research Council guidance. So we use these frameworks to put together our topic guides and our measures that we used for the project. For the singing interventions themselves, we drew on ideas from the structure of the groups of the Royal College of Music Studies. So that's the 10-week intervention that you've already heard about, with each country exploring how to adapt the programme to ensure its suitability for new environments. And you've also just seen quite a bit about what we did in Romania. So each country delivered a 10-week programme delivered by professional singing leads, and there was also time for socialising. The locations of each of the groups varied. They included a music room at a school in Denmark, a room in healthcare facilities in Italy, and community centre locations in Romania. From our implementation data, we constructed 5 key interrelated themes. So this was from the qualitative data. The first theme explored the feasibility and acceptability of the intervention, such as in relation to its content and its structure, the suitability of the project team, and the suitability of the intervention for supporting postpartum depression. So, for example, one mother said it's primarily down to the people, and another that it's useful and beneficial for their mental health, suggesting that it was experienced as feasible and acceptable. The second theme looks at barriers and enablers in relation to participating in the classes and implementing the intervention. For example, one mother said, "My son didn't sleep, it was exhausting to go," so that's a potential barrier. And then another saying that they didn't have to think about childcare, so that was something that potentially supported them in going. The third theme was about adoption and sustainability of the intervention, and this was primarily in relation to the need for a better infrastructure to continue. So one manager said we need to try and continue the momentum, and another that we can't depend on the systems quite yet. So although we were able to deliver this short intervention, there were some questions raised at how they would possibly sustain this in the future. The fourth theme explores broader contextual factors that affected implementation, such as in relation to mental health stigma. This is particularly in the context of Romania, and a lack of structured pathways, again, building on the previous themes. So one referrer said, mothers do not trust the healthcare system, so that was a problem. How do we get people to actually join this if people don't trust the healthcare system? And that there were a lack of structured referral pathways in order to ensure that people could hear about this and attend it. And finally, the fifth theme looked at our project structure and processes, highlighting that our unique organisational collaborations and training programme delivered by Breathe enabled successful implementation. So the stakeholders were described as a rich network of professional health, non-health and cultural contexts. So as you can see here, that very broadly, the intervention was perceived as being acceptable and feasible, and it was a success. However, there were clear challenges from a structural perspective, and that there needs to be more consideration of how we can sustain these programmes in the future. Moving on to our impact findings, although it was a small sample, as you can see from these 3 graphs, the intervention did have an overall positive impact, with decreases of postpartum depression, increases in well-being, and increases in sense of social support. There were statistically significant findings for the EPDS, which was the measure for postnatal depression, and the WHO-5, which was the measure for well-being, in each of the 3 countries, but it was only in Romania that the social support measure was significant. But what we really need to remember here is that this is a very small sample size with no control group, and that the purpose of including these measures was to complement our implementation findings to evaluate the success of implementation. So we weren't actually really looking for clinically relevant findings here. It was just about what's the perceived impact, and are we seeing the similar trends that we'd seen in the previous trial, which we were seeing here. And there were also some...
minutes, please, Katey.
How long?
Just 5 minutes, please.
Okay, fine. Yeah, I'll be handing over to Calum just shortly. So just here are some quotes that demonstrate the positive impact. I won't read them all out because of limited time, but I think one to highlight just because of the limited time is that I think this one at the bottom here that says, "I also feel I can bring a bit of the magic with me when I'm at home," is quite important because it shows that there's potential wider behavioural change as a result of participating in interventions such as this. So it's not just about the moment of singing, it's about the things all around it. And I'll hand over to Calum now.
Thanks so much, Katey. So a brief word on the outputs that we've produced from this project so far. The first one is this BMJ open piece, which is the abridged version of our protocol, which Katey mentioned previously. And this is one thing that we've been sharing with potential future partners who are potentially interested in adapting interventions to different cultural contexts. The second one is this frontiers piece on in the bottom, which is brief research report from the initial findings from Romania and Denmark. And the key thing to note with our project is it kind of happened in 2 overlapping mutually informative phases because the Italian team came on slightly later. So this report features some of the results that Daisy shared earlier. And the third paper in the top right here was published last week. This is findings from the Italian group, and it has specific information on the Italian context. So there's analysis from the qualitative work with implementing partners and mothers in and implementing partners and mothers in Italy. And a quick quote here before moving on from a singing lead from Italy, which demonstrates how music and motherhood can help in a unique way. They said, "It's about offering a group activity at a time when isolation is one of the worst enemies. One mother told me, I don't know if a discussion group would have helped me at that time, because sometimes when I'm in psychotherapy groups, I feel less than others. Instead, having an activity to do together allowed me to be on equal footing and then slowly to tell my story." Can we skip to the next slide, please, Katey? Actually, I'll skip this for time and on to the next one. Thanks so much. So a brief word on the reports that we have published and are intending to publish shortly. So first, the research report, which is still in process. So this is going to be the kind of go-to place with the source of lots of the data, the implementation findings, as well as the specific metrics that Katey measured to measure the effectiveness from others. Next is a meeting report. We had a big meeting in October 2023 about the project, bringing together participating implementing partners, as well as folks from Breathe and the WHO to kind of spread the word. So there'll be a meeting report coming out shortly. And the key thing is this thinking tool. And here's the front cover of it here. And this will be coming out hopefully early-ish next year. And the aim was to take the learnings that we've taken from this project to inform arts and health implementation work going forward. And this isn't necessarily just singing projects, but all kind of adapting and implementing to different cultural contexts going forward. Thanks, Katey. And I've included this visualization here because these are some of the key considerations that informed our implementation and adaptation work. And this isn't prescriptive or exhaustive, but it's some of the key things that we learned for implementation. And the reason we use this kind of system dynamics-esque visualization is partly to show the interconnectivity and non-linearity of this kind of implementation project, and to show the centrality of people in the project. You can see the people node at the center there. And a quick word on other arts and health work at the WHO going forward. We're really lucky to be working with Rosie on an arts and health project for mental health of young people in Greenland, and this kind of implementation and adaptation considerations are helping inform that project as well going forward. And quickly before finishing up, a word on next steps for the project and for the project partners. So since taking on this project, our partners in Denmark did similar work before, but they've received funding to carry on music and motherhood interventions for the next 3 years. In Italy, there are 9 new groups, starting 3 in Bologna, 2 in Rome, and some more in northern Italy. And these projects are starting shortly going forward. In Romania, we've heard from our project partners that some of the mums are meeting up separately to run these kind of community groups, but without any kind of specific organizational oversight, partly because of resource restrictions in place. We've also been talking with folks from a hospital in Geneva who are interested in running this kind of intervention going forward. And a final word on a community of practice. So we've been working with Lorna and the team at Breathe about bringing together some folks from these countries, but also other countries. We've been in conversation with folks from Portugal, Australia, Ireland, and more to kind of bring together a community of practice united about the potential for adapting music and motherhood to different cultural contexts. So yeah, thank you so much for your time, and thanks again for your invitation. It was a real honour and privilege and delight to work on this project, and it's great to be able to share it with you. I'm looking forward to our discussion and to watching the conversation grow. Back to Katey for a final word.
Yeah, thank you so much, everyone. I think with the time, we'll just move on to the discussion. Yeah, thank you.
Well, thank you so much. That was really splendid. And so there's lots of hearts for you. So without further ado, I'd like to invite Rosie to offer some comments or questions to our presenters before I open it up more widely for further discussion. Rosie, perhaps you might introduce yourself rather than me do it for you.
Yes, of course. Hi, everyone. Lovely to be here. First and foremost, thank you so much to all of the speakers for those fabulous presentations. I'm Rosie Perkins. I'm based at the Royal College of Music in London in the Centre for Performance Science, and I research around music and mental health and wellbeing with a particular interest on parental wellbeing, as we've been hearing about this evening. First and foremost, I just want to say how moving and fabulous it is to hear about all the work that has been happening in this space. I know speakers and we're in regular contact, but I haven't heard it all presented in its entirety like this before. So well done. Congratulations on the work, and how wonderful that this is happening in so many contexts now. As I was listening, I wrote down a few words that just sort of seemed to capture threads that were running through the different presentations. And these words were care, support, evidence-based, reflective, sensitive, collaborative, ambitious, culturally sensitive, thoughtful, and hopeful. Earlier this year, I had the privilege of editing a book on music and parental mental well-being, which many of the people here today on the call contributed to. And at the end of that volume, which showcased music, including singing practices with parents in many different contexts, I attempted to pull out some sort of next steps, things that I thought we needed to think about and develop in this area. And many of those next steps resonate with what we're hearing this evening. So the first one was around the need for implementation and scale up, which of course has been the focus of what we've been speaking about. And I have many, many questions for the speakers on that, which hopefully I'll have time to throw a couple of those at you in a second. The importance of recognizing that so much of the work that happens in singing and music and parental well-being is often very local, quite small scale, and how we get it from that to what we're hearing tonight is not only fascinating, but vital in terms of how we think about developing and sustaining the work in this area. And it also brings with it questions about how we know what works, what's important for us in terms of what quality means in this context, and how can we collectively and collaboratively come up with that understanding of what good quality looks and sounds and feels like. One of the other areas was around diversity and representation, and needing to diversify the types of parents that can be involved in this sort of work. And Lorna, you very briefly mentioned melodies for dads, and perhaps if we have time, we can circle back and hear a little bit more about that. And Calum, you also mentioned the importance of sort of PPI and adaptation in culturally sensitive ways. And again, I'd love to hear more about that and how that worked in practice in the different settings and contexts that you were working in. And the third area that I was reflecting on is important to our next steps is around sort of capacity building. And by that, I mean how we can support and train practitioners who are working in these sorts of contexts, and how we can care for them when they are facilitating and leading this sort of work. And again, there was a brief mention of some of the training that I think Breathe delivered for the work that happens in the implementation study. And it would be interesting again to hear a little bit more about that. So those were the sorts of areas I thought we could begin with: implementation and scale up, diversity representation and capacity building. And perhaps I'll just throw a question out to the panel in the first instance, which is, it seems that we're at a really exciting moment in terms of the momentum, the community, and the inherent feeling to me that this is something that parents want to do. And that feels absolutely essential in terms of all the things about acceptability and feasibility that we've been hearing about. From your perspective and from your experience working in this field, what's the single most important thing you think we can take away in terms of what enables implementation to be successful? What's the thing that you would tell other people thinking about to really take on board in terms of making an implementation and scale up effective and successful?
I'm happy to jump in there if nobody wants to go first. I don't know if it counts as like one thing, but I think it's about collaboration and working on the ground with partners and the culturally sensitive nature of this, and ensuring that you're working in partnership with people on the ground. I think with our study, as you've heard, like we had London involved, we had the WHO involved. These were distant partners, whereas what was actually happening on the ground, that's where the decisions needed to be made. So actually, I'm less keen on the word scale up, if I'm honest. And I prefer the idea of enabling people to lead these projects from within the cultures and creating them themselves, and using this as inspiration and taking ideas from what's happened before and then adapting that and thinking through, well, what might work in our context. I'm sure everyone on the call here will be aware of the social movement towards co-production in research. And I think that is absolutely essential here, like working with mothers to co-design projects and make sure that this is something something that works for them in their new environments, rather than necessarily saying, well, this is something that has worked before in the UK, so I'll take that and deliver it. I think it really needs to be done very sensitively, very carefully, with mothers with experience on the ground of those countries and of the policy landscape in which that's being delivered as well. As I noted, in Romania specifically, there's a lot of stigma around mental health. So it wasn't the case that we could deliver this in the same way. We had to think very carefully about what would happen for a mother attending this within their social circles as well, and talk about that. So in summary, I would really say it's the collaboration, the co-production for me that I think is absolutely crucial.
Yeah, thank you, Katey. I completely agree. Did anyone else want to come in on that point?
Yeah, I just wanted, I absolutely echo what you've just said. And I did mention at the end of our presentation as well that we had an event completely dedicated to looking at how this shape of research can be used to kind of leverage these kind of the collaborations and connection and scaling up. Just to maybe counter that slightly, just because we're having a kind of discussion here, I wonder if, just thinking about scale, there's a positive element to scaling up, in that if we can create kind of tools and resources to support interventions that we know really work, that are evidence-based, that have a huge impact on people's health and well-being, then actually, if that means that they can reach more people, is that a bad thing? I think, that said, I totally agree with what you just said, Katey. I think collaboration and partnership has to be at the heart of it. And that's not just when we're working in, working internationally and kind of providing, supporting with the knowledge we've learned and kind of sharing that with others to take on board and implement in the context they know best. But also, even like in this country, nationally, we have such localized community connections and networks, and it's so important to work and listen and work in collaboration with those networks. It doesn't work otherwise, and you need to listen to the people who who can benefit from participating in these interventions, and they have to be absolutely like at the center of the co-design and how they work. And yeah, so kind of agree, but also adding a bit of a counter there as well on scaling.
Thank you, Lorna.
Thank you, everyone. It's coming up to 6 o'clock, so we've been going for an hour now. We've got a further half an hour if you've got the stamina to stay with us. And I'd like to open it up to everybody that's with us at the moment, and ask whether anyone would like to make comments or ask questions for people on the panel. So please indicate whether you'd like to do that, and I can bring you in. Baz, are you able to see that as well? I don't seem to be able to see everyone at the moment for some reason.
Yeah, you should get a sign when people are putting their hands up, but
yes,
there might just be a bit of shyness to start with.
Yes, I can't see.
Oh, Lauren. Feel free to unmute yourself, Lauren.
That would be a good idea, wouldn't it? Hi, everybody. Thanks to the speakers. Interesting to hear all the results from such a range of different settings. I'm very curious to know when the Shaper trial results, the main ones, are going to be in, because that's obviously the critical question. And yeah, so is that on the, when would we know, or when is it data crunching right now, or how close are you?
So we are set to present on November 19th. We have an event to go through all of the results from all three of the projects within the Shaper program. So by November 19th, we will have all of our data analyzed and ready to be presented. And at that point too, we'll start submitting the papers for publication.
Okay, sure. It'd be good to see those. And also I was wondering about implicit. It's always, it's always difficult, but kind of really important to think about if there's any complementary measures to the self-report. So I don't know if you've had thoughts, or of anything new in the literature that gives us a good clue of you know, more implicit measures of like social connection, or these kinds of things? Because I mean, we are kind of stuck with self-report. I'm going to talk about some work we're doing in that's a bit similar, but in Africa next time. But yeah, we're thinking hard about the right measures to use and what we should, what we need to be thinking of. That's not just self-report.
I think one measure that we use across all the studies that I've worked on is the SCID, because you're right, there's definitely a difference sometimes between observational measures and self-report ones. And so the SCID is a great one because it gives you at the end a clinical diagnosis. So we did that with all of the mothers who were enrolled in our trial, to see whether they met clinical criteria for depression. And then we kind of looked at whether that was correlated with their EPDS score, because the EPDS more gives you the severity rather than any kind of clinical diagnosis. But I agree that it is important to have observational or clinician rated or just non-self-report measures, because there can be a bit of a discrepancy sometimes.
Sure. And I was also looking back at the pilot study, the 2018 paper, and it is interesting to see that the results are seen at week 6, and then at week 10 things narrow. So the program was a 10-week session, but the between group differences was seen just at that.
We've lost you, Lauren.
Oh, never mind. Have I gone?
No. I think we just lost the sound momentarily.
Right,
Would you like to repeat the point?
Well, it was just to say that I was looking at the original paper and noting that the effect was seen at the week 6 and not at the week 10. So I was wondering if there's thoughts about what's going on there, because it was a 10-week program. So yeah, that's it's just something that, you know, the evidence, I think it's a bit nuanced in a way, in terms of when you look at the different time points. So if you had any thoughts about what's going on there. And I also noticed that different things that you've talked about, sometimes the programs are 6 weeks, sometimes they're 10 weeks. So thoughts about sort of dose would be welcome as we try to you know, do similar things in different contexts.
Yes, thank you, Lauren.
I'm happy to talk about the dose, and perhaps Becky, you can chip in, because I think just to say on the 6 weeks versus 10 weeks, when we were looking at pivoting delivery to online during the pandemic, we weren't actually sure, because I think none of us are really sure how it was going to work out. We weren't actually sure whether people would sign up for 10 weeks online. We weren't really quite sure whether that would be too much. And actually, so I think just it feels like a long time ago now, but I think we decided that actually to run it for at least 6 weeks, where we know group singing can have an impact, was the kind of a good place to land. Sorry, Rosie.
Rosie, did you want to come in?
Just very briefly, Lauren, I completely agree that it's extremely nuanced. And it struck me, Becky, when you were talking, that I think I'm right in saying that the change was over 3 weeks, or that there was a change evident over 3 weeks, which is even quicker than the 6 weeks where we saw the initial change, which is why we were kind of careful to present ours as it sped up the recovery, because it was a quicker rate of recovery. But actually by week 10, as you say, people were landing in a similar place. And I suppose we would expect symptoms of postnatal depression to reduce over time for many people, which perhaps explains some of that. But it really struck me that the 3-week change you saw suggests some sort of really quite quick effect. And I just wondered, Becky, what your thoughts were on that, if I'm remembering and interpreting it correctly.
Yeah, I think we were struck by that too. And I wonder if part of it is we were in lockdown, and these mothers were very isolated and didn't have social contact. And so having this group that they could come to every week probably is what drove them to not recover, but improve so quickly, just because it was providing them with some kind of social contact, something to do with their baby, a routine when we were in a time of not really being able to leave home. And that would be my guess.
Yes. If I may just add something in relation to this, in all of the projects that I've been involved in, offering singing for health and well-being for people with a variety of different health challenges, who may not have sung before, you really have to capture people's interest and engagement immediately, because there's always the risk that people will attend an initial session, not enjoy it, and not come back after that. So you really, and I've seen that over and over again, that if you have a very competent, skilled musician leading leading groups, they will very quickly draw people in and engage them and create a very positive atmosphere, and people will go away feeling that they've had a good time and they want to continue to engage. So in that sense, it doesn't surprise me that you can see effects quite quickly in these kinds of projects. Katey, did you want to come in?
Just a small point, which kind of links into what Rosie was saying, really. I do think it's important for this particular intervention to remind ourselves of the severity of postnatal depression, because if it's left untreated, it can lead to suicide, and it's one of the leading causes of suicide as well in the UK. Obviously, statistics vary in different locations. So the fact that this speeds up recovery, even if it does level off, I think we cannot underestimate the importance of that for something that's very serious for new mothers experiencing postnatal depression. So I just wanted to kind of highlight that in case people weren't aware of the potential severity of this.
Thank you. Thank you. Do we have any further? Liv, I can see your, oh no, I see you're applauding, Liv, but Liv, would you like to make a comment or ask a question?
No, it was just to echo what Katey was saying. And I think, if there's some kind of preventative or slowing down, or, you can push stuff into the long grass, then, that has to be a good thing. That was all.
Thank you. Thank you. I wonder if my colleague Katarzyna is here from Salzburg still. Katarzyna, we've talked about the possibility that this initiative might be established in Salzburg or elsewhere in Austria.
Yes, I'm here. Thank you.
I'm inviting you to contribute, because I'm just wondering what the avenue might be to establishing a similar kind of project in Salzburg. Could you just introduce yourself and tell people what it is you're doing there in Salzburg?
Thank you, Stephen. I'm Katarzyna Grebosch-Haring, and I'm a senior scientist at the University Organization Science and Arts at Salzburg University and Mozarteum University Salzburg, and I'm also director of Salzburg Institute for Arts in Medicine in Salzburg. And I really spoke with Rosie about this possibility, and we spoke with University Clinic about this possibility, and also with the new ambulance for psychotherapy. And we will try to start with the project next year. It was not easy to have a group for, maybe the project will be a little bit different, because we wanted to combine it with the psychotherapy and singing. This is the standard here in Austria for depressed mother, to have this kind of care like psychotherapy. And this is why we would like to combine it. And it was not easy to find depressed mother for the group therapies for psychotherapy. So, but we will have new start in next year, and speak then with Rosie and also with Lorna. We would like to have the course from Lorna to learn a little bit more about the intervention, and to try to have a pilot next year. Yeah.
Thank you, Katarzyna. So we've got lots of people with us. I'm sure there must be other questions or comments that people would like to make.
Stephen, Claire's got a hand up. Claire Turner.
I don't know. I can't see everybody for some reason. I don't know.
Sure. Claire, do you want to dive in?
Claire, please do.
Hi, everyone. Thanks so much. I work for the Singing for Health Network, and that was just such a joy to hear about all those wonderful projects. So thank you so much. I've also been working on summarising the research articles to go on the Singing for Health Network website for members. So I've really been engrossed in that material for the last few days, and it's just been fascinating. So thanks for all your hard work. I've just got a few questions. I won't take up too much time, hopefully. I just wondered whether there was a cut-off point for on the Edinburgh postnatal depression scale for being too high. Don't think it mentions that, as far as I'm aware, anywhere in the literature. I know it was 10 plus, I think. Just wondered if there was a cut-off point, or whether that was just more done in terms of a baseline assessment, sort of going a bit further into assessing each individual participant.
We didn't have a maximum threshold. It was our cutoff for enrollment was 10, a minimum of 10, because that way we could ensure that they were experiencing symptoms of postnatal depression. But we didn't have, I would say probably the majority of mothers who we enrolled in the trial were kind of in the mid-range of the EPDS, so somewhere between probably 14 and 18 or 14 and 20. We certainly had some mothers who scored very high on the EPDS, especially on the more severe questions about suicidality, but they were probably the ones that we would monitor more closely with safeguarding, but we didn't exclude anyone if their score was too high.
Great. That's just, it's just interesting in terms of thinking about other projects that are looking to work in that area, and whether they would feel quite as confident to work with such a high severity of participant. I guess you were probably more able to have processes in place, but just sort of thinking about smaller scale projects. There's one that I've been sort of supporting where I live, Milton Keynes, where that we talked about those issues as to whether, whether there was a kind of ethical issue with perhaps not actually assessing. So in that project, as far as I remember, they didn't actually assess with the postnatal depression scale. So whether that's an ethical issue, but also whether you do assess and then refer on if they're too high. So just thinking about that, and particularly in terms of what Rosie was saying about trying to link up those smaller scale projects that are happening elsewhere, and sort of trying to understand the best way to support those and sort of protocols. Sorry, that was not really a question, that was just an observation. And then I was interested in the sort of the demographics, which I know is something that's sort of a bit more broadly across the Singing for Health sort of arena. It feels like there's a high percentage of white and highly educated within that. I think that's been picked up upon in some of the sort of broader research, and just thinking about how we start. Again, this project was trying particularly to link into different ethnicities and different demographics, and I think it was particularly challenging, the one that I was helping with where I live. So I'm just opening up that question really as to how we can start to try and sort of attract different demographics, and within that I would also be interested to know what degree of interest in singing there was already for the participants. Again, that might not be something that was necessarily looked into, but I think it's an important area, because if we're only reaching out to those people who are interested in singing, then we've got quite a sort of a narrow area. So those are just my thoughts, kind of just opening it up to how we can broaden things.
So Claire, just to sum up, I think an important point was around diversity and inclusion, wasn't it, really?
Yeah.
So, and any thoughts on that?
I mean, I think absolutely that we need to focus more on diversity in the future, and there's just a lot more that needs to be done. I mean, certainly in the context of our trial, it doesn't always come down to resources, but I do think resource was a limitation, and the time frame of the study was quite short. And I know we hear this a lot time and time again, and it's unfortunate that resources in this area are reasonably limited. But I do believe that if we'd have been able to work more closely in partnership with local communities, that we could have involved more diverse groups. And also we really need to kind of flip the narrative, not about including people in our work, but us working to support and enable people within the work that they want to deliver. That might not always be singing, that might be something else, that might be working in partnership with a dance group or a football club or whatever it is for a particular community. So I don't think we can always say like singing is the right thing. It's very much about that culturally specific collaboration, co-production again, and trying to not impose certain ideas. And that's particularly important when working in non-Western countries, because it can be seen that singing for health is a potential more of like a Western dominated terminology. So even the language itself needs to be culturally specific and adapted in view of the context in which you're working. But absolutely, I agree with you that it's a massive limitation and something that absolutely has to be addressed in the future. And hopefully governments will recognise this and invest in the future so that we can ensure that these really are inclusive programmes for everybody.
Thank you, Katey. Thank you.
I think
Anne was
this,
next. Anne, do you want to go?
Yeah, thank you. Can you hear me?
Yes.
Good. Okay, thank you so much. Yeah, thank you very much for your presentations. It's really interesting to hear about your research. Yeah, just to introduce myself, I'm a PhD student at the National Institute of Public Health at the University of Southern Denmark, and I have a question about which measures to include when you're doing studies like this. So we're currently doing a feasibility study of a school-based singing program in 3 different public schools in Denmark. And we're looking at the implementation, but also initial results. We don't have a control group, so we'll just see. We're looking at efficacy signals. So in our study, we've included W05 and the Strengths and Difficulties questionnaire, and we have data both from teachers and from parents and from the students themselves. And we'll have our 1-year follow-up data in about a few months' time. But seeing as it's a universal school-based intervention, we've had discussions about whether these measures are the right ones to use, because we don't have a population that necessarily has any particular health issues. It's a universal intervention as such. And hopefully we'll be able to do a control study after feasibility. But so I'm just wondering, based on your experience in this field, which measures would you include in a universal intervention like this? And I'm asking broadly for anyone really.
And this is a study with children, and the work is taking place in schools. What is the age range, Anne?
The age range is between 5 and 10.
5 and 10.
Yeah.
I think you've stumped us all.
Sorry about that. I'm happy to give more information, of course, but yeah.
We have other programs that we run at Breathe, and we run evaluation, not necessarily research of those programs. And I think when you're designing those, again, like co-design of evaluation is so important. It's not just co-design of the programs, it's also understanding if you're reaching these young people in school, for example, what is useful to the school, or what do the school use already and collect already that you could tap into, I think. And then also obviously there'll be an appropriateness of the measures that you're using with that group, particularly as they're quite young. So I think, again, it's really, really considering what's appropriate to use. I'm saying this as a program, manager and kind of rather than a researcher. So, others may have better suggestions, but just in terms of how you design that evaluation, I really think co-design, again, is so important.
I mean, I think it's such a broad question, which is why maybe we're not answering so quickly, because it's quite specific to your context. I think I would need to sit down certainly with the research question and think very much through like what would be appropriate in this environment. And I'd be nervous to make any recommendations in situ. But what I can recommend is a resource that we put together at UCL called Navigating the Landscape, which is all about evaluation. And in there, there's a section on choosing measures where we provide links to measures. And there's like banks of measures that exist, and you can go through and you can explore which ones you think might be relevant for you. So I'm going to pop that link in the chat. And I also highly recommend a book by Rosie, which maybe you might be able to remember the title of it, the Performance Science Research Methods one, which also talks about choosing measures and evaluation. And just the chapter on research questions is absolutely amazing around like designing your study around those questions. So I think having a look at Rosie's book and this evaluation guide to me would be the best starting point to thinking through which measures, both from a theoretical perspective around research design and a practical perspective around working through those measures banks. And hopefully that's helpful.
Thank you, Katey. That's wonderful. I'd also mention the work of Graham Welsh. He was the evaluator of the National Sing Up programme here. And you may well know him and his work, but I certainly think that that's a good point of contact to see how they approached the evaluation of that national programme. Baz, could you maybe add something in relation to that?
Yes, I certainly can. And there were some fairly extraordinary results of that research to have worked at the scale they did for 4 years, I think in total, was it was in the days when governments used to give millions to things like this, and so that was in terms of the massive advocacy of that piece of work for the value of normalizing singing in any setting as a way to achieve wonderful things. I mean, it found all sorts of other things, but that was really the big finding, that the growth in singing competency, in the enjoyment from it, the impacts on self-efficacy, everything. Just make it normal, and it's then you get the magic. There's one more hand up. So perhaps before we finish, Katey Rose, are you happy to say something?
Hello, everyone. I'll make it quick. But I'm Katey Rose Sanfilippo, and I actually have a question that sort of builds on something that we were talking about earlier, and this is for everyone that has spoken today, which is around sustainability. I think it's a struggle that I think it seems like everyone is dealing with, but especially with the work that's done in these different contexts, how you approach sustainability of these projects. And even in the video, you heard the woman, say, I really miss this. I'm really going to miss this. So I think sustainability is quite an important aspect of scale. And from your own experience, what are some of the things, of course, collaboration and things like that, but how do we get this really embedded within all these different healthcare systems, or what is some advice that you might have?
Thanks so much for your question. Just to jump in super quickly about some of the stuff that we did with sustainability in mind. And it kind of links to some of the questions earlier about what helps the project be successful in these different contexts. We had lots of discussions in PPI sessions with the implementing partners at the start about recruitment mechanisms and who is involved in recruitment. And each of the 3 countries, recruitment was done differently. So in Denmark, it was done with healthcare nurses. In Italy, it was a hybrid model. And in Romania, it was done separate to the healthcare system. And I think being sensitive to, like Katey mentioned, stigma, but also the ways that there can be buy-in from the kind of places where mums will regularly go to. So part of the reason why that it was easily fundable again in Denmark was because healthcare nurses were kind of the key and central, if only, font through which mothers access this program. So in terms of sustainability, it's like making sure that people that will access or be in contact with mothers experiencing PPD going forward are aware of the project. Don't know, Katey, if you've got anything to add about that.
I think really just to again emphasize what you're saying about buy-in from the healthcare system, because in Italy, I was actually shocked at how quick the buy-in happened. Like from my experience of working in the UK, it can be quite challenging, a lot of email, social media to try and recruit people in, very difficult. In Italy, it was like we had people from within the system recruiting people directly from their appointments into the intervention, really exciting. And in Denmark, as Calum said, we had healthcare nurses on board from the start, and they'd also had training, they'd had a trial of the singing session, they had that buy-in from early on. So it was really embedded in the healthcare healthcare system. It wasn't a formal social prescribing mechanism, but to be honest, it was working like one. They were recruited through the healthcare system and then they were into the intervention, and that's supported with the sustainability of this. I think what we see time and time again, often in implications or limitations of studies, is that there's less buy-in from the healthcare system and that it's arts policies and cultural policies that are dominating. And when we did a policy mapping exercise at UCL, there was a much lower percentage of policy documents from the healthcare sector globally. So it's not even just in the UK. So I think what we really need to try and do to enable the sustainability of this is to get buy-in from the healthcare sector and money from the healthcare sector, so that it's not squeezing all of the cultural budgets, which are all project driven and really time limited. And there are a lot of challenges as even sustaining the arts with outside arts and health. So it's not really an answer, but I think it is raising a challenge, and potentially, hopefully, trying to get that inter-sectoral collaboration will help towards work towards more sustainability in the future.
Katey, thank you so much. Thank you. Lorna, just one final comment then before we wrap up.
Yeah, I was just going to add to that. I think something huge for us with the Breathe Melodies for Mums programme recently is, as I mentioned, we were commissioned as an evidence-based intervention for parental mental wellbeing and parent-infant bonding. We weren't commissioned because we're an arts and health intervention. We were commissioned because we're an evidence-based intervention that has, has that research behind it that shows it has an impact on that area. So I think, again, it's that sea change of people thinking about these programs as more than just an arts and health intervention, that actually there's this huge evidence base behind it, and they can be embedded into mainstream health and social care to have a real impact. But then obviously it's still retaining that accessible and inclusive element of it, because actually some of the barriers people face to accessing healthcare may exist if we're being commissioned by them. So I think we just have to keep that inclusive, accessible element to these arts and health interventions, but whilst trying to encourage the people who are commissioning services to think of this as something really rigorous and evidence-based that can work.
Thank you, Lorna. That's an excellent comment to finish with. I'd just like to say that this programme will continue next week and the following week with further webinars on the singing, and here we are. This is what's coming up on the 14th of November and the 21st of November. We have a number of people contributing from their experience working in this field. So please do sign up for these webinars if you've not done so already. And so it just remains for me to thank Lorna and Becky, Rosie, Katey and Calum for their tremendous presentations today. I think we really have learned a great deal, and we know that there is more to come. And we will, I'm sure, all look forward to seeing the full findings from the SHAPER trial and reading the reports that are due to come from the implementation projects in Europe. So thank you very much. Please show your appreciation with hearts and flowers and things and balloons this time. Thank you. Thank you, everyone, and good evening.